And welcome to Med Search 2. This is Mrs. Camden. We're going to be talking about Chapter 18 today, the cardiovascular system. That starts on page 371 of your textbook. The objectives for today's lesson are to describe the normal anatomy and physiology of the cardiovascular system as opposed to the disease processes that we'll be talking about in class on Monday. We're also going to discuss the risk factors and incidences of cardiovascular disease. So first we're going to talk about the structures of the heart and remind ourselves of what the structures are. I put this picture up there hoping that you could pause the video at this point and try to figure out what and label these structures on your own. But I'm going to go ahead and go over them with you. And the heart has four collecting chambers. It's the smaller chambers on top are called the atria, and singly they're called atrium. This one that I've circled is the right atrium, and then over here is the left atrium. Down on the bottom are the ventricles, and we have the right ventricle and the left ventricle there. The left ventricle is the largest, has the largest muscle of the heart, and that's because it needs to push the blood all the way through to the body. Between the atrium and ventricle are valves, and those are called, easily enough, the atrioventricular valves, or AV valves. Between the right atrium and right ventricle, we have the tricuspid valve, and between the left atrium and left ventricle, we have the bicuspid valve, also known as the mitral valve. From the ventricles up into the vessels that they're connected to, we have what's called semilunar valves. From the right ventricle up into the pulmonary artery, we have the pulmonary or pulmonic semilunar valve. Okay. And then the other semilunar valve that is in the heart is from the left ventricle up into the aorta, and that is the aortic semilunar valve. So those are the valves of the heart. The vessels that we talked about that connect the ventricles and the semilunar valves are the first one right above the pulmonic semilunar valve is the pulmonary artery going this way. And it's pulmonary because it connects to the lungs, bringing unoxygenated blood to the lungs. Now it's an artery, and we kind of think that might be a little funny that it's got unoxygenated or deoxygenated blood in it. But if you think that arteries always bring blood away from the heart, so here we have blood going away from the heart to the lungs. So that's a pulmonary artery. Coming back in from the lungs, we have the pulmonary veins. Okay, so pulmonary veins. And that's connected to the left atrium. In the middle, dividing the ventricles, we have the septum right here. And then the heart is, what I really want you to remember is the muscle of the heart is called the myocardium. The other vein or vessel that we have is the aorta. Okay, right here is the aorta. It connects the left ventricle to the body, and that's where blood is distributed to the rest of the body. Okay, so now we're going to talk about blood flow through the heart. And we know the structures of the heart now, but blood flows in a certain direction, or it should at least flow in a certain direction. And first, it comes in from the body through the superior and inferior vena cava here. And this is deoxygenated blood. The blood then empties into the right atrium right here, going through the tricuspid valve. Okay. Tricuspid valve connects where the blood goes into the right ventricle. Then the blood flows up through the pulmonary semilunar valve into the pulmonary artery. The pulmonary artery branches off to hit both lungs. And the blood, deoxygenated or unoxygenated blood, goes into the lungs for gas exchange, and that's where the blood becomes oxygenated again. That process going from the right atrium through the tricuspid valve into the right ventricle, into the pulmonary artery, up through the lungs, and then now back through the pulmonary vein, that is pulmonary circulation, going through and getting oxygenated. So here we are now going into the pulmonary vein, in this way too, and we're coming into the left atrium. The blood then flows through the mitral or bicuspid valve into the left ventricle. Blood going from the left ventricle up through the aortic semilunar valve into the aorta, and then going out to the body is called systemic circulation. So we have pulmonary circulation and systemic circulation. Pulmonary involves the lungs and the blood being oxygenated. Systemic involves the system and the blood going through the system. There's one other circulation that I want to bring up right now, and that is the hepatic portal circulation. Hepatic portal circulation is the last chance circulation. Blood goes up through the hepatic or liver and gets one last chance to filter out too much glucose and other toxins in the blood. So it does that, and then it finally goes up into the inferior vena cava, into the heart and the lungs. So that's your body's one last way to filter the blood before it gets to the important important organs of the body. Okay, the cycle that we just talked about with the blood going through the whole heart and the lungs and out to the body, that one cycle of it is called the cardiac cycle. It consists of contraction of the muscle, which is called systole, and relaxation of the muscle, diastole. So one cycle of contraction and relaxation, or systole and diastole, is called the cardiac cycle. The heart itself pumps out about 5 liters of blood every minute. That's about how much blood an average person has in them, but in 1 minute we're circulating that much blood. The ejection fraction is a percentage of, the percentage of the blood that is ejected from the heart during contraction or during systole. The heart does not pump, or the ventricle does not pump all of the blood out of the heart. Instead, it pumps out a certain amount, a certain milliliter or a fraction of it. So the ejection fraction is the amount of blood pumped out of the ventricle divided by the total amount of blood in the ventricle. That gives us a percentage. The normal ejection fraction is 50% to 70%. So if we have something lower than that, we know that we've got kind of a weaker contraction. Now, stroke volume is the amount of blood ejected by the ventricle during the contraction. So instead of being the percentage, we just have that milliliters of blood being pumped out with one beat. And that's what the stroke volume is. So cardiac output equals the stroke volume, so the amount in milliliters of blood that is pumped out at one contraction, and we multiply that by the heart rate. So cardiac output is heart rate times stroke volume. The amount of cardiac output that we just talked about depends on several different things. It can depend on the heart rate, how fast the heart is going or how slow. The amount of blood returning to the heart, which is the venous return. If we don't have a whole lot of blood returning back, then the output's going to be lower. The strength of the heart contraction, so if we have a weaker heart, if our ejection fraction is lower, then we're going to have a lower cardiac output. And the resistance to the ejection of the blood. So if our pressure in our aorta is really high, the heart is going to have a harder time pushing out blood, and therefore the cardiac output is going to be lower. Okay, so we've talked about the chambers and the inner parts of the heart, but now we need to talk about the coronary arterial system. And this is the heart's way of getting oxygen to that muscle, the myocardium, which is the heart muscle. If you look here, you'll see that the coronary arteries branch off of the aorta. So here's our aorta right here, and we've got the coronary arteries branching off of it. So what happens is the left ventricle will contract, and then as it relaxes and allows blood to flow and fill into the left ventricle, blood that was ejected out of the left ventricle during contraction into the aorta during relaxation will filter back down and go in to the coronary arteries. And that blood feeds that muscle, the heart muscle. So the heart muscle, the myocardium, is the first muscle to actually receive oxygenated blood, which is important because our heart needs to pump and needs that blood. You can see here that we've got the right coronary artery and also the left coronary artery, and they branch off into several different arteries that feed all the muscles of the heart. So just like we had on the last slide, we had an arterial system that fed the heart muscle itself. Once that muscle is fed and the blood is deoxygenated, then now we have veins that are going to collect the blood and bring it back and dump it right into the right atrium right here. Okay. So how does that muscle itself, the cardiac muscle, beat? Where does it get its stimuli from? Well, the heart has its own stimuli, its own conduction system and electrical system. It starts up here at the SA node, and the SA node is the sinoatrial node. The sinoatrial node, then it fires and we get stimulation onto the right atrium, over in the left atrium, and then it goes down to the atrioventricular node here. The atrioventricular node, also known as the AV node, slows down the impulse. We then have some firing going on down the stem of the ventricles through the bundle of His. There's the right bundle branch and the left bundle branch of the bundle of His. And finally, we have the Purkinje fibers, these little fibers at the end that actually do the stimulation of the ventricles. And once those Purkinje fibers stimulate the ventricles, that is when the ventricles contract. Okay, now I want to talk about arteries and veins. First, I want to talk about blood flow through the arteries and veins in the systemic circulation. So when blood is ejected from that left ventricle, it gets ejected into the aorta, which is an artery. The aorta connects to several arteries within the body. The arteries then get smaller and turn into arterioles. The arterioles connect to capillaries, which the capillaries are a connection between arteries and veins. And capillaries are the one cell layer where gas exchange happens. The capillaries then connect to small veins called venules, and then venules connect to the veins, which the vein then is connecting to the heart at the inferior and superior vena cava. Arteries and veins alike have three layers. They have the endothelium, which is the tunica interna. We have the tunica media, which is the smooth muscle of the arteries and veins. And you can see that the artery has a larger tunica media than the vein. And then we have the tunica externa, which is the outer layer of the arteries and vein. And the differences between the arteries and veins is the artery moves blood away from the heart. They have increased pressure in them and have to deal with increased pressure because they are closer to the heart's pressure of the contraction. And so they have a thicker, smooth muscle layer, or that tunica media. Veins are opposite. They have lower pressure because they're farther away from the heart. So they have to have several different mechanisms to bring the actual blood back up to the heart. One of those is a huge difference between artery and veins, is veins have valves in them. And they're one-way valves. They open up, allow blood to come up, and then they close, and the valves should not allow blood to flow back down. Another way that veins get blood up to the heart is by muscle contraction. And so when a muscle is contracted, it helps to push the blood up through the vein as well. Okay, so we've talked about veins and we've talked about pressure in them. Arteries and veins, and we've talked about pressure. But we're going to talk about arterial blood pressure. Arterial blood pressure is measured in a systolic and diastolic fashion. We obviously use a blood pressure cuff to measure it with. The systolic blood pressure is the pressure against the artery when the ventricles are contracting. So systole, contraction. So systolic is that blood pressure at the time of contraction. And then diastole or diastolic blood pressure is the pressure in the artery when the heart is relaxing. Pulse pressure is actually the difference between the systolic and the diastolic blood pressure. So if you have a patient that has 120/80 blood pressure, the pulse pressure would be 40. And 40 is a pretty average, a good number for pulse pressure. Anything above 60 for pulse pressure can mean that the patient may have a leaky valve or some type of regurgitation going on. And then anything lower than 30, 35 can mean that they have a weak heart. But we have to remember that there are 5 things that affect blood pressure. So when we're measuring pulse pressure, we want to make sure that none of these things are affecting the blood pressure so we can get an accurate view of the heart. The 5 things that affect blood pressure are resistance to flow, so that would be the contraction or dilation of the vessels. When the vessel is more contracted or has a smaller diameter, then the blood pressure is going to be higher because the heart has to pump harder to get the blood flow through a smaller diameter. And then the opposite if there's a larger diameter. Next thing is heart rate. Eventually, if the heart rate is up long enough, then blood pressure is going to go up as well. Strength of contraction plays a huge part in blood pressure. If you've got a weak heart, then blood pressure's not going to be as elevated. because you're not pumping as hard. Blood volume plays a big part in blood pressure. So when you've got someone with extra fluid on their system, as in congestive heart failure or in pregnancy, their blood pressure is going to be elevated because the heart has to overcome that extra volume. And then blood viscosity, the thickness of the blood, also plays a part. If you've got a milkshake that you're trying to suck through a straw, it's going to be harder. You're going to have to put more pressure to suck that milkshake up through the straw versus if you've got water, something thinner. Alright, there are other things that affect blood pressure and our body's way of compensating, and one of them is the renin-angiotensin-aldosterone system. We're going to talk a little bit more about this in the next chapter, so in chapter 19, but I wanted to just give you a little bit of a brief overview of it. And what it is when the kidneys actually sense that the body's volume is low, they produce what's called renin. Renin then mixes with angiotensinogen to make angiotensin 1. Then we have a converting enzyme that makes it into angiotensin 2, and then those are converted into aldosterone, which helps the body to maintain or reabsorb water and sodium, bringing our volume back up, which brings our sodium level back up. There's several causes of cardiovascular disorders. Some of them are from birth or congenital. Several of them are acquired throughout our lifetime. We can have heart failure as we age. We can get older and our heart just fails us and gets weaker. You have dysrhythmias, which are problems with the conduction side of it. Definitely can have infection or inflammation of the heart or vascular system in general that can cause issues. Diabetes mellitus and metabolic syndrome, those both are huge risk factors and indicators of cardiovascular disease. If a patient is diabetic, they usually are treated as if they have a cardiovascular disorder already. And then things like obesity, sedentary lifestyle, and stress all contribute to cardiovascular disease. Now, risk factors for cardiovascular disease can be broken down into two sections, one being unmodifiable risk factors and the other being modifiable risk factors. Unmodifiable risk factors come to us like heredity, race, sex, and age, so things that we can't change in our life. We're born with these things. Heredity is if our parents have a cardiovascular disease, then we are at increased risk for cardiovascular disease. Race, people that are African American have a higher risk factor for cardiovascular disease than those that are Caucasian. Males are at a higher risk for cardiovascular disease up until the age of 65, when females start to have about the same risk as males. And then age, at that 65-year-old age is when people have more heart attacks and are at an increased risk of cardiovascular disease. So those are all things we can't change. But the modifiable risk factors are great in the sense that we can control them, we can change them. So maintaining a healthy weight can decrease our risk for cardiovascular disease. Now, high cholesterol and hypertension may look to you like, well, sometimes they are genetic factors and maybe unmodifiable, but the reason that they're modifiable risk factors is that even if you have genetic high cholesterol and genetic hypertension, you can modify that with medication. You may not be able to modify it with diet and exercise, but you can modify it with medication. So that's why those are modifiable. So we want to have a low cholesterol level, lower than 200, and have a normal blood pressure. Those can decrease your risk of cardiovascular disease. Having diabetes, again, like I said before, automatically puts you on a risk of having cardiovascular disease. Cigarette smoking causes a lot of vasoconstriction, so that puts a lot of stress on your heart and can cause put you at risk for cardiovascular disease. Sedentary lifestyle, not exercising, having too much stress, and sometimes we can't control the stress that's in our lives, but we can control how we handle it. So trying to find out ways that can help us control stress in our life will help us decrease our risk for cardiovascular disease. Excessive alcohol intake. If you have more than 2 drinks for men and one alcoholic drink for women per day, then you're at more of a risk for cardiovascular disease. And then cocaine and methamphetamine use put you at a high risk for cardiovascular disease and sudden cardiac arrest because it puts so much stress on your heart. So those are the risk factors. I do want you to write down your unmodifiable and modifiable risk factors for cardiovascular disease, just so we can look at it in class. And that way, if we are looking at our modifiable and unmodifiable risk factors as nurses, then we can help our patients understand this as well. And if we set ourselves goals, then maybe our patients will do that as well. Okay, metabolic syndrome is a diagnosis of these things that we're going to read in just a second. But it has to be, you have to have 3 or more of these things to be considered metabolic syndrome. Metabolic syndrome puts you at a high risk of having cardiovascular disease. So having an elevated waist circumference of more than 40 inches or more than 35 inches for male and female. Having elevated triglycerides above 150, having a reduced HDL, which is our good cholesterol. So if you have less than 40 and less than 50 for men and women, having elevated blood pressure at or above 130/85, having an elevated fasting glucose above or at 100, so it's kind of low if you think about a fasting blood sugar, 100, so you need to be lower than that to not have one of these indicators. So remember, you have to have 3 or above of these to be considered metabolic syndrome. Diagnosis of the cardiovascular system comes in several different tests and diagnostic procedures. We are going to go over those in class and actually get into groups and do an online presentation for this. Diagnosing cardiovascular system disorders starts with the assessment and data collection. First off, the nurse or doctor will take a history by asking the patient several questions, so about their risk factors, about dyspnea or chest pain, and then a focused assessment comes about, and we do that by doing several different things. First off, our heart assessment. If you remember, we listen to the heart for at several different places, so at the aortic, the pulmonic, the tricuspid, and the mitral placements on the chest. And we're listening for the lub and dub sound. We want to only hear lub and dub, no extra sounds, no swooshing, because lub and dub indicate a regular heart rate, regular sounds. We want that to be regular, not irregular. But lub is our S1 sound, and that's actually the closure. What we're hearing is the closure of the mitral and tricuspid valves, or the AV valves. The dub sound is S2, and it is the closure of our semilunar valves. Also, the mitral valve placement that we're listening to, that's where we listen to our apical pulse. It's at the mid-clavicular line between the 5th and 6th intercostal, And it is also called the point of maximal impulse. That's why we listen to the apical pulse there. And we listen for 60 seconds, correct, to find our apical pulse. Aside from the heart assessment, we're also going to be assessing vital signs, which include pulse, oxygen saturation, and blood pressure. Pulse, when we do our pulses, we always want to feel for strength and regularity. We want to do pulse quality, which is on page 387 of your book in box 18.2. It goes from 0, that's what you would call it, being absent. If you couldn't find a pulse, you would put it as 0. And then all the way up to full and bounding, which is 4. So the normal is 3. That's what we would call a normal feeling pulse there. Oxygen saturation, by doing an oxygen saturation, not only tells about our respiratory status, but it tells about our cardiac status, because if we're not getting blood to the tips of the fingers, then we're not perfusing to that tips of the fingers, and it can tell us how our perfusion, our oxygenated blood is traveling through the body. Blood pressure obviously tells us about how well our heart is pumping. And I want to remind you that on our blood pressure, we need to make sure that we are using the correct size cuff, because if we use too large of a cuff, the blood pressure is going to be too large of a cuff is going to be decrease the blood pressure. If we use too small of a cuff, like on me, then the blood pressure is going to be elevated. Next, we're going to look at the skin color. If the skin color is pink, then we know that blood is getting to the skin and the tissues adequately, and oxygen is getting there. If it's blue or cyanotic, then we know we're not getting blood there. There can be other things too, like we're going to talk about on Monday, different colorings that mean that there's an issue with the vessels of the system. We also look at lung sound, or listen to lung sounds and look at edema, and that can tell whether our heart is pumping correctly, because if we have fluid escaping into the tissues or into the lungs, we know that there may be a backup of the heart. Mental status is another picture of our cardiac system, cardiovascular system, because if we have hypoxia, then our brain is not getting enough oxygen, and the patients become confused and foggy. And then pain, chest pain, is a patient having pain. So those are the things you need to look at for a cardiac assessment. If the patient is on telemetry, then we need to also be looking at the telemetry, the heart monitor, and assessing that heart rhythm. And in class, when we talk about conduction disorders, we're going to be learning more on how to read a rhythm strip, but I just want to go over again with you on the simpleness of it. We first have the P wave, the QRS, and the T wave. And remember, that's a little bit of an elevated T wave, it shouldn't be that big, but remember we also measure the PR interval, the QRS interval, and the ST interval, and we'll be talking more about that later. Some common problems of patients with cardiovascular disorders is that they're often fatigued, they have dyspnea, they have a hard time walking, they get a lot of any type of exertion, they're just tired and out of breath. They can have fluid overload, which will add to their dyspnea. They can have pain, chest pain, or just achiness if they're not getting a lot of blood to the areas that they need to. They obviously have altered tissue perfusion, which leads to impaired tissue integrity, causing a lot of tissue problems. I want you to, these are great nursing diagnoses for people with cardiovascular disorders, so I want you to come up with 2 interventions for each of these nursing diagnoses that will write them down so that we can discuss them in class, because when we have a cardiovascular disorders patient, when they come in, we should automatically think of these nursing diagnoses and the interventions that we can do to help the patient to not have any other complications or just to make them more comfortable. All right, I'll see you in class on Monday. Have a good weekend.